especially this program tonight with the elite panelists and the colleagues is hosted by Dr. Haytham Algameel. Dr. Haytham Algameel is consultant cardiothoracic anesthesia in Aberdeen Royal Infirmary Hospital in UK. He is formerly assistant professor in anesthesia and consultant cardiothoracic anesthesia in King Fahd University Hospital in Saudi Arabia. Dr. Haytham Algameel, he is a friend and supporter and endeavor supporter to the MEGA online course, and he's going to be thankfully moderating this very, very special webinar with the great panelists, Professor Nuha Sharnovi and Professor Sherif Sultan, and our eminent colleague from Canada tonight, Dr. Ahmed Higazi. He was here with us 2 weeks before about ultrasound and is going to continue his series. All the best of luck for you, and I'm sure you are going to enjoy this special program tonight. All for you, Dr. Haytham. Thank you.
Oh, thank you very much, Dr. Saad. Really, it's a very wee introduction with lovely words. I appreciate that. Really, it's a warm words that conduct really the main purpose of this kind of course. Ladies and gentlemen, I would like really to be honored and to really express my deep appreciation for Dr. Saad and for the MEGA Online for hosting, give me the main host for this kind of a lovely session over the upcoming 2 hours. I would like really to thank you all for attending our tonight's session in the MEGA Online Learn, Engage, and Connect. Tonight's session is really an outstanding session because it's highly professional session. The main purpose of this session actually is to take you over a very nice tour through the management of the critically ill patients. Let me say that if you are interested to know more about the intensive care management of the critically ill patients, especially the nutrition, and if you are looking for the management, or let me say how to know more about the serotonin syndrome, or if you are ambitious to know more and to be more familiar with the thoracic echo for the valvular assessment in the critically ill settings, probably you are, and definitely you are in the right place and the right time with our eminent experts in those fields and those aspects of management. On the behalf of you, actually, I need to welcome and conduct my warm welcome for all the eminent speakers on the panel tonight, and to Professor Sherif Sultan. Honestly, I can't hide really my curiosity to know how we can deal with the serotonin syndrome. This topic actually came to the news recently, and I think it attracts the attention of many of our pain clinicians. It actually came under the radar of many of our colleagues as well, and even for those who's been sitting for the exams as well. So I think it's really a very attractive topic to be considered for all of our junior colleagues and all of our trainee residents as well. How we can diagnose in terms of knowing the symptoms, the signs, and how we can know the causes of this serotonin syndrome, how can we manage it? I think Professor Sherif Sultan, the professor of anesthetics and intensive care and pain management in Ain Shams University, Cairo, Egypt, will be the speaker for this really interesting and outstanding session. Professor Sherif Sultan actually have a very long record of publications in national and international peer-reviewed journals as well, up to 200 almost. And he's really have the being many endeavors in the field of intensive care medicine, critical care medicine, and as an instructor in ECLS, BLS, ATLS courses. You have a very wide experience in life-saving protocols. Thank you, Dr. Sherif, for being with us, and it's over to you.
Thank you very much, Dr. Haytham Algameel. Assalamu alaikum wa rahmatullahi wa barakatuh, everybody. Bismillah ar-Rahman ar-Rahim. This lecture is about serotonin syndrome. I just want first to thank my brother, Dr. Saad Mahdi, for his great effort to make this course worldwide and reaching every anesthesiologist all over the world and reaching every country and starting to educate all the anesthesiologists here and there. Thank you again, Dr. Saad Mahdi, for your effort. Jazakallahu khairan. I need also to thank Dr. Haytham Algameel for his nice presentation. And I'll start soon with the serotonin syndrome. I hope the lecture of Dr. Anoha will be ready after this lecture, inshallah. First of all, we need to know about the physiology of serotonin and serotonin receptors. Serotonin is synthesized centrally in the CNS and also peripherally. Centrally in the CNS, it is concentrated in the serotonergic pathways, which are in high concentration in hypothalamus, thalamus, limbic system, cerebellum, spinal cord, and in the retina. Peripherally, the serotonin is synthesized in the enterochromaffin cells of the intral nervous system, in the mast cells, and in the platelets. Central serotonin is controlling and sharing in control the mode of everybody, the wakefulness, appetite, sexual behavior, emesis, temperature control, and also shares in the pain pathways. While peripheral serotonin is concerned with the intral motility, intral secretions, and share in the overall vasomotor tone of the body. Synthesis of serotonin starts with L-tryptophan, and with the enzyme hydroxylase, it is converted to L5-hydroxytryptophan. Then with decarboxylase, is transferred into 5-hydroxytryptamine, which is the serotonin, or as we all call it, 5-HT. This serotonin is used to be broken down by the monoamine oxidase enzyme to 5-hydroxyindole acetaldehyde. Serotonin receptors in the body have many types. There are 7 types categorized as 5-HT1, 2, 3, 4, 5, 6, and 7. All these receptors are G protein coupled receptors, except 5-HT3, which is a ligand-gated sodium and potassium channel. This 5-HT receptor is the one concerned with the postoperative nausea and vomiting, as you all know. There is subtypes for each type. For example, 5-HT1 have got subtypes of 5-HT1A, B, and D, while 5-HT2 have got the subtypes A, B, and C. What's important, and the important receptors here are 5-HT3, as you know, for controlling postoperative nausea and vomiting, 5-HT2, which is the main receptor where the serotonin do its function and do its serotonergic effect. An important receptor also is 5-HT2A, which is the main receptor that is included in the serotonin syndrome, and 5-HT1A, which is the main site where drugs with serotonergic agonist or serotonergic receptor agonist can work. This diagram shows the overall creation and the overall production of serotonin from L-tryptophan in step 1, and then formation of serotonin will collect in vesicles, and then release from the presynaptic neuron to the synapse through rupture of these vesicles, and then combining to the receptors, which the most important of them for the work of the serotonin is 5-HT2 receptors, Then the serotonin dislodges from the receptors, and the uptake of the serotonin back to the presynaptic neuron, where it is metabolized in the mitochondria with the act of monoamine oxidase drug enzyme. Other drugs with serotonergic receptor agonist activity can work on 5-HT1A receptors. What is the pathophysiology of serotonin syndrome? The overall definition of serotonin syndrome, it is a hyperstimulation of postsynaptic serotonin receptors. Most important in them is the 5-HT2A, as we said a few minutes before. These receptors are the main one included in the serotonin syndrome. In animal studies for serotonin syndrome, they found that there is high concentration of norepinephrine in the hypothalamus, suggesting a big role of norepinephrine in the pathophysiology of the serotonin syndrome. For serotonin syndrome to occur, there should be two important things together in the same time. First is the serotonin syndrome precipitants, which are the serotonergic drugs that increase the overall amount of serotonin in the synapse. We call them serotonin syndrome precipitants, and some other people call it the serotonergic drugs. These patients with serotonin syndrome precipitants, when they are focusing serotonin syndrome trigger, the serotonin syndrome starts to manifest in signs and symptoms of serotonin syndrome. This serotonin syndrome triggers usually are in the form of methylene blue or fentanyl or ondansetron, whatever. We are going to talk about them in few slides. However, not every patient with serotonergic drugs that might face the triggers will develop serotonin syndrome. This is because of the individual variability and the genetic differences between people. So the serotonin syndrome precipitants or the serotonergic drugs, we can classify them into according again to this map. In step one, if we are going to increase the amount of serotonin produced. In step two, if we are going to increase the amount of serotonin released to the synapse. Step three, if we are going to decrease the amount of serotonin breakdown by the action of monoamine oxidase inhibitors. Step four, if we are going to decrease the uptake of serotonin back to the presynaptic neuron. And step five, if we have drugs with serotonergic receptor agonist activity. These drugs we can classify in this table, this heavy table, but you are going to explain briefly here. Drugs that might affect or increase the serotonin synthesis are usually the L-tryptophan itself or the oxytryptan. While drugs causing enhanced release of the serotonin to make a big amount of serotonin in the synapse are in the form of amphetamines, cocaine, some opioids like fentanyl and mebridine and tramadol, and the drug of the abuse drug, which is the ecstasy, the abuse drug of serotonin. Number three, drugs with serotonin receptor agonistic activity, like triptans, somatriptan and zolmitriptan, and you all know that these drugs are famous in treatment of migraine. Ergot alkaloids, again, another drug used for treatment of migraine. Buspirone, fentanyl, and lithium, these drugs can directly attach to the serotonin receptor and causing a serotonin syndrome in some patients. Drugs that inhibit serotonin reuptake, the most important here is the SSRI or selective serotonin reuptake inhibitors like the paroxetine, sertraline, and fluoxetine. And SNRIs, which are the serotonin norepinephrine reuptake inhibitors like the duloxetine. Tricyclic antidepressants also are an important drugs that start the serotonin syndrome. and ondansetron and granisetron also can share in inhibiting the serotonin reuptake. Drugs that affect the serotonin metabolism are monoamine oxidase inhibitors, antidepressants, and the drugs with monoamine oxidase inhibition activity like the methylene blue and hydralazine. To review all of this again, these are the drugs that we can call it serotonin syndrome precipitants. We can call it serotonergic drugs that increase the serotonin formation or increase the serotonin release here, or increase the serotonin receptor agonism, or decrease the serotonin reuptake, or decrease the serotonin metabolism. All these groups of drugs share in developing the serotonin syndrome. Serotonin syndrome triggers, the most important between them is the methylene blue. Then comes the fentanyl and some other opioids, and in some cases, ondansetron could be, it's claimed sometimes to produce serotonin syndrome. How can the methylene blue induce serotonin syndrome? Methylene blue usually works as a monoamine oxidase inhibitor and inhibit the breakdown of serotonin to its metabolite. So its work is here, as you can see here, on the mitochondria of the presynaptic neurons. While the opioids, especially fentanyl, play three roles. One of them is inhibition of the reuptake. Here, inhibition of the reuptake of serotonin to the presynaptic neuron, making a big amount of serotonin in the synapse here, and stimulating also the release of more serotonin. And sometimes it combines with the 5-HT1A receptor working with as 5-HT agonistic activity of some drugs. Ondansetron works on 5-HT receptors, blocking these receptors and making the serotonin available for combining with other receptors and inducing also serotonin syndromes. This is how these drugs can share and start the serotonin syndrome. The epidemiology of serotonin syndrome, usually the average age of patients with serotonin syndrome is 58 years old. Females more than male. As you can see, 60% of cases are females, 40% are male. The symptoms and signs of serotonin syndrome. First, we need to talk about the onset. Usually the onset is sudden, and for frequent time, immediately post-operative, patient might suffer the serotonin syndrome. The timing of the serotonin syndrome exactly will depend on the exposure to the triggering agent. So it should be 24 hours or 48 hours after the exposure of the triggering agent. While the duration depends on the serotonergic agent and the washout of the serotonergic agent from the body of the patient. But know that the elimination half-life of some drugs like the SSRI, like paroxetine and sertraline, are 15 hours, while other drugs like fluoxetine have 7 days to wash out from the patient body. There should be a triad of three things so we can diagnose the serotonin syndrome. Patient will complain of altered mental status, autonomic hyperactivity, and neuromuscular irritation. Serotonergic drugs, or as we say before, the serotonin syndrome precipitants. The famous altered mental status are the agitation, confusion, anxiety, restlessness, excitement, delirium, and coma. While the autonomic hyperactivity usually incited like hypertension, tachycardia, diaphoresis, hyperthermia, nausea and vomiting, diarrhea, and mydriasis. The neuromuscular irritation signs are usually tremors, clonus, hyperreflexia, muscle rigidity, and what's called akathisia. The serious complications of serotonin syndrome are rhabdomyolysis, myoglobinuria, And the resultant from the previous two is the metabolic acidosis, renal failure sometimes, seizures, and in 3% of cases, death. There is two sets for diagnosing, two sets of criteria to diagnose the serotonin syndrome. First is called Sternbach criteria, and the other is Hunter criteria. Sternbach criteria, if we have 3 or more of these criteria, we can diagnose the serotonin syndrome. But again, in patients with current or previous exposure to a medication with serotonergic activity. These changes are mental status changes, myoclonus, agitation, hyperreflexia, shivering, tremors, diarrhea, incoordination, and fever. If we have 3 or more of these criteria, we can diagnose serotonin syndrome according to Sternbach criteria. Hunter criteria have got a more specificity and sensitivity to diagnose serotonin syndrome. Hunter criteria are only 5 if we have one of them in a patient with current or previous exposure to medication with serotonergic activity, we can diagnose serotonin syndrome. First is spontaneous clonus. Second is inducible clonus plus agitation or diaphoresis. Third, again, clonus, ocular clonus plus agitation or diaphoresis. Fourth is the tremor plus hyperreflexia. And the last one, if the patient complains of hypertonia plus temperature more than 38 degrees centigrade plus ocular or inducible clonus. If you notice here that clonus is mentioned many times for out of these 5 criteria, and the clonus is very important to diagnose serotonin syndrome. What is clonus? What is inducible clonus? What is ocular clonus? We can see now. From this video, ocular clonus and spontaneous clonus is evident. As you can see here, this is not nystagmus. This is ocular clonus. Here, the spontaneous clonus. This is the same patient. If you can see here, the hyper-irritable muscles, skeletal muscle. This is the spontaneous clonus, as you can see in the left arm. Next is the inducible clonus. This is the inducible clonus. Hold the leg with one arm and then do a dorsiflexion. You can see the inducible clonus here. It is extended and it is due to irritability of the neuromuscular junction. The most common clinical presentation for serotonin syndrome is agitation. Then comes the delayed recovery from anesthesia and then confusion. The most common autonomic hyperactivity is hyperthermia, then tachycardia and diaphoresis. The most common neuromuscular agitation signs are nystagmus, clonus, then myoclonic jerks. Surgical specialty that we face the serotonin syndrome within this specialty is mainly the cardiac surgery, due to the wide use of fentanyl in cardiac surgery and also the presence of methylene blue to treat hypotension in cardiac surgery units. Then comes the orthopedic and general surgery, and finally the head and neck surgery. Usually the patient are under the drugs, usually in 65% under SSRIs, okay? So most of the patients are under SSRIs, the one used for depression. 7% of cases under effect of atypical antipsychotics, 7% under tricyclic antidepressant, 5% are under the effect of gamma aminobutyric acid analogs like the pregabalin, 5% under the effect of amphetamines, and 11% under monoamine oxidase inhibitors, ergot alkaloids, and sympathomimetic amines like ephedrine and also tramadol. As you can see here, Many drugs are there that for patients with psychotic treatment, for patients coming from pain clinic, are affected with serotonin syndrome due to the presence of these drugs for the patient that will face, if facing the serotonin syndrome triggers, will develop the serotonin syndrome. 52% of cases are methylene blue is the trigger, 15% is fentanyl, and then comes other drugs like mibridine, remifentanil, ondansetron, oxycodone, and finally lidocaine. Death is only a complication in 3% of cases. Prolonged ICU stay in only 3% of cases, and discharge home in 94% of cases, while 6% of cases usually discharged to a rehabilitation facility. Usually there is no laboratory or imaging test specific for serotonin syndrome. It remains the diagnosis of clinical presentation of the patient. There is no correlation even between the serum serotonin level and the severity of serotonin syndrome. If you find in the lab tests some metabolic acidosis, if you find increased liver enzymes or increased creatinine or leukocytosis, this means that this is a reflection of severity of organ dysfunction. And if the patient developed rhabdomyolysis, there will be an increased serum creatinine phosphokinase in the blood of the patient. We need to differentiate serotonin syndrome from other syndromes. Starting first with the malignant hyperthermia. You all know about malignant hyperthermia. It is a family history disease from exposure to anesthesia, like halogenated anesthetics like halothane, and depolarizing neuromuscular blockers. And what's famous also is that the temperature exceeds 41 degrees centigrade. If you can see here, a rapid review of malignant hyperpyrexia. Exposure to halothane and dexamethasone is important. Rapid increase in temperature, more than 1 degree every 30 minutes, masseter spasm, cyanosis, hypoxemia, hypercarbia, and metabolic acidosis, hyperkalemia, and arrhythmia. Second, we need to differentiate serotonin syndrome from the anticholinergic syndrome. You will find the history of exposure to anticholinergic agent like atropine or drugs with atropine-like effect. The patient is complaining of hypervigilance, agitation, hallucination, delirium, mumbling speech, and coma. The patient usually is hyperthermic with mydriasis, tachycardia, and hypertension, while the drug, the skin is dry and mucous membrane are dry, and there is myoclonus, and the bowel sounds are decreased, and sometimes there is urinary retention. The anticholinergic toxidrome, you all remember from the days of the toxicology, is mad as hatter, blind as bat, red as beet, hot as har, dry as bone. Also, we need to differentiate serotonin syndrome from opioid toxicity. Usually you will find the history of exposure to opioids. Either the patient will tell you, or the relatives, or his colleagues. Patients have got meiosis, hypothermia, respiratory depression, and hyporeflexia. Again, here the toxidrome, blue or purple cyanosis, unresponsiveness to voice and touch, pinpointed pupils, hypoventilation, bradycardia, pale clammy skin. We need to differentiate neuroleptic malignant syndrome. Also from serotonin syndrome, you will find exposure to antipsychotics this time, or neuroleptic agents. Usually it starts with gradual onset. The rigidity is led by rigidity or slowly moving rigidity, fever, dysautonomia, but no GIT signs at all. We need also to differentiate serotonin syndrome from the delirium. It's with its acute onset. Patients usually complain of inattention, disorganized thinking, altered level of arousal, but no neuromuscular activity activation signs at all in cases of delirium. In cases of sedation, hypnotic withdrawal, you will find history of chronic intake and abrupt cessation of some of benzodiazepine, alcohol, baclofen, barbiturates. Patient is usually confused and agitated, autonomic dysfunction may be present, but no inducible clonus in case of sedative hypnotic withdrawal. Now we pass to the management of our serotonin syndrome. The management is, first of all, to discontinue and stop the potential trigger. The trigger should be stopped. For example, if it is a patient under methylene blue infusion, fentanyl infusion, or PCA fentanyl, for example, we should stop it until the serotonin syndrome precipitate wash out from the circulation of the patient. Until this, we need supportive care in the form of adequate hydration, oxygenation, and the proper monitoring until the patient comes out of this period. If the patient have got agitation or anxiety, we can give the patient benzodiazepines in the form of midazolam or lorazepam. But the best here is the older drug, the diazepam, because diazepam may attenuate the development of hyperthermia. We can give diazepam 5 to 10 milligram IV, will be very beneficial for the patient. Another alternative for benzodiazepines is the dexmedetomidine, which is the Brisidex. We can start the infusion dose without loading dose. It decreases the central sympathetic output from the brain and effectively controls hypertension and tachycardia in our patient. The autonomic instability is usually hypertension, not hypotension. So treatment of hypertension should be with short-acting agents like ismalol. We can give a loading dose, 500 mic per kg bolus over 30 seconds, and then give infusion 50 to 300 mic per kg per minute. Or we can give tridyl or glyceryl trinitrate. However, hydralazine is contraindicated because this drug have got significant inhibitory effects on monoamine oxidase and may exacerbate serotonin syndrome. If the patient developed hypotension, we can treat it with norepinephrine, epinephrine, or phenylephrine. However, dopamine and ephedrine are contraindicated because they inhibit the activity of monoamine oxidase, and this will exacerbate serotonin syndrome. Hyperthermia in this patient are usually due to muscular hyperactivity. So paracetamol is not effective. Dantrolene is not effective. What's effective here is using topical cooling, and if it is a little bit severe, we can use the benzodiazepines, as we said before, especially diazepam. If still the hyperthermia is high because of the hyperactivity of the neuromuscular junction, we can give the patient sedation, even or starting the neuromuscular blocking agent and starting mechanical ventilation. If we're going to give neuromuscular blockers, we should not use succinylcholine because of the fear of the life-threatening hyperkalemia that might occur due to rhabdomyolysis and metabolic acidosis. If all these measures fail to control serotonin syndrome, we can give a specific serotonin antagonist. What's famous here is sebroheptadine, and this drug is a H1 receptor antagonist with 5-HT1A and 5-HT2A receptor antagonistic activity. We'll give the patient 12 milligram stat, then 2 milligram 2 hourly. Maximum dose in 24 hours will be 32 milligram. These drugs are tablets, should be given orally or in nasogastric tube if the patient is intubated. Another alternative for sebroheptadine is chlorpromazine, which is the antipsychotic agent with 5-HT2A receptor blockade. Now, this is the final slides. Should we discontinue the serotonergic agents before surgery? If the patient is under, for example, SSRIs or under other drugs, should I inform the patient, please stop this drug before you come to OR? The answer is no, because abrupt cessation of these drugs is associated with unpleasant withdrawal symptoms and exacerbation of psychiatric conditions. While my prevention should focus on avoidance of known triggers, and we all know it now, and early identification of signs and symptoms of serotonin toxicity, and we all know it now. A special attention should be taken with, if I'm going to use methylene blue in a patient with psychotropic therapy. And the overall of serotonin syndrome is a rare condition. So I should not stop the SSRI, for example, or the serotonergic drugs before going to OR, and it should continue with my special attention. Thank you very much.
Thank you, Professor Sherif, really for a very interesting topic and very interesting and very informative slides. Really, you've been, you've been flowing really very smoothly through the management. Um, Honestly, I have this kind of curiosity really because such syndromes actually being faced very frequently in the critically ill management. I mean, especially in some of our ITUs, and those really could never be discovered immediately by the aid of like imaging techniques, like in the form of the CT, as you mentioned.
Yes.
And moreover, it requires the people who have a very good intelligence to pick such symptoms and signs, and moreover, just to have their, let me say, a very, very wide experience in order just to start the diagnosis and definitely take part of the management. I have a question here for you, Prof. Sherif, and for instance, if we have a potential to prescribe, let me say, a prescription for those patients, would you prefer to start with the antipsychotic before starting the like the paracetamol, or I mean for the hyperthermia and such things? I mean, should we just patients usually kept on antipsychotic as a main treatment for such syndrome?
So for the treatment of the syndrome, I need to wash out this drugs from the body.
Yep.
So I should wait until it is washed out according to the elimination half-life of the drug the patient on. Okay. And then I think after the treatment and rehabilitation of the patient, we can reconsult and recheck if we can give the patient again the antipsychotics or not.
Wonderful. And another question. Do you think that for instance, let me imagine that I have a patient who is going for a cardiac surgery.
Yeah.
And this patient will go on bypass. And perhaps definitely, I think that those patients usually have potential to be diluted. I mean, let me say that with the initiation of bypass technique, definitely those patients have a potential to be filtered. Does this kind of maneuver would help those patients to have really less let me say, potential to develop such kind of syndrome?
I think the dilution will be beneficial for some patients. However, you know that, for example, as I mentioned here, some drugs are washed out after 7 days. In these 7 days, the drug is not in the serum and not in the blood to be diluted. It will be in the target itself, in the CNS, affecting the patient. So sometimes, according to the drug used, will not be beneficial to the dilution of the patient on bypass will not be that beneficial, I think. But it will be beneficial for the short-acting drugs if the patient, for example, taking some drugs, for example, pregabalin, for example, I think will have some benefit from this syndrome by the dilution over the cardiopulmonary bypass. But other drugs with longer acting effect, like the ergot alkaloids, like the triptans, also like the SSRI and the SNRI, the overall of the psychotropic drugs are longer acting drugs, not the usual we use in our practice, anesthetic practice and ICU practice. We usually the short acting drugs as usual. So I think not all the drugs will have the benefit from dilution on the bypass. Some drugs only.
I know that in many European countries as well, I mean, the threshold of receiving the antipsychotic medication are very low. So usually most of the patients sometimes have been really complied on the antipsychotic medications. However, I believe that this is my another query as well. If we, I mean, do we have an interaction between the pregabalines or the gabapentins and the management or the treatment is being given? I mean, do they get any benefit if those patients been received any pregabalines or gabapentins?
What's mentioned in our lecture, the pregabalin or the GABA drugs in general are not that increasing very much the serotonin level or the serotonin in the synapse that effective, but it may use as triggering the serotonin syndrome. I mean,
okay,
if the patient receiving other serotonergic drug and then receive the pregabalin, serotonin syndrome might stop.
Okay, that's
I think, according to my review of literature.
That's wonderful, really. Professor Sherif, thank you very much, really.
Thank you very much,
personally, I enjoyed really, I get really a very, very wide, let me see, knowledge about this kind of syndrome. Honestly, I was enjoying the slides from the beginning till the end. Thank you very much, really, for your input and for your very informative presentation.